Yeah, once again, good evening, everyone. Welcome to our bi-weekly sessions. I think we have around 7 cases, all interesting cases. So without further ado, once again, thanks, Dr. Balthauser, for joining us. I think Anish also has joined us, so that's great. Without further ado, we'll start off with our first case. The chat is open for your comments and suggestions, so feel free to use the chat box. Over to you, Apurva.
Yes, sir. This is 1 year, 6 month old male child, developmentally normal. This child presented with complaints of trivial fall at home associated with minor concussion to the head, followed by which the child cried for 2 minutes and slept for 30 minutes. The child got up from sleep after an hour, and as the child was found to be lethargic and had recurrent episodes of vomitings, following which he had one episode of seizure, which was associated with eye deviation to the left and unresponsiveness that lasted for up to 5 minutes, aborted by midazolam spray, and the child was admitted in Rainbow Hospital, Vijayawada. On examination, at the time of admission, after the postictal state had aborted, the child was awake, irritable, lethargic, and not recognizing parents, with pupil 2 bilaterally equal reacting to light. Child had central hypotonia with power 2 by 5 in all the four limbs, and child was afebrile with shallow respiratory effort but maintaining saturations on room air. But previously, also, there is a similar complaint of a child having a trivial head injury 3 months prior to the current admission associated with lethargy, irritability, seizures, followed by central hypotonia and recurrent vomitings and shallow respiratory efforts, for which the child required ventilatory support. During this admission, the child underwent MRI, which is.
Okay, so yeah, this is the MRI after the second episode, I think the most recent one. We have diffusion ADC sequences, and you can appreciate that there is right-sided cortical abnormalities in terms of restricted diffusion, predominantly in the perisylvian regions out there. The temporal lobes also involving the hippocampus, the right hippocampus, possibly also involving the polygonothalamic nuclei on the right side. The left also was suspicious for some changes in the temporal lobe, but they do not show reversal on the ADC sequences. So predominantly right-sided cortical and some degree of subcortical abnormalities, and also involving the thalamus and the hippocampi on both sides. The T2 images demonstrate the edematous changes which are seen on the diffusion panel. Again, you can see that the hippocampi are edematous on both sides, more predominantly on the right side. The flare sequences again demonstrate the temporal lobe abnormalities. Another additional finding I think the child had was these multiple tiny cysts in the parotid gland, possibly suggestive of some chronic viral infection out there. So chronic parotitis is what we thought, or benign cystic lesions. Based on the imaging findings, the imaging differentials at the time were given as possibility of a postictal edematous changes or an infection causing this. But given that the child had recurrent episodes and there was a clinical suspicion of possible channelopathy, we thought of at least these imaging findings could match the findings which are seen in the index child, such as the ATP1A2 mutation and the CATNA1 mutation. I'm not sure if it fits into all the clinical phenotype fits, but at least on imaging, these are the channelopathies which I found were had the similar findings on imaging. The other possibilities in terms of imaging was MELAS was another differential. I don't think the child was encephalopathic, but if it's so another differential was MOG-related changes predominantly affecting the cortical regions. So these were the imaging differentials, and we have a follow-up.
The child underwent whole exome sequencing in view of recurrent minor trivial traumas leading to such findings. And then there was a CATNA1 mutation, exome 32, which is known to cause such kind of trivial trauma related affections in the brain.
Okay, so the uncertain significance, is it parental tested or is it not required? Or
So clinically,
the VUS?
it is matching.
Okay. All right. So I mean,
is the mutation de novo or familial?
No family history of any migraine or any other possible associations with CATNA is known.
But you have not yet done genetic testing.
Of parental testing, not done.
Thank you.
Yeah, so then we looked up again, as we have mentioned, CATNA1 mutation can have these diffusion changes, especially if there's recurrence, as demonstrated here, two separate episodes at 3.5 years and 5.5 years. And this child also had hemiplegia. This is, I think, one of Dr. Lokesh's patients. You can see that the left limbs do not move in comparison to the right side. And this was a review which we found that head trauma patients with channelopathies, and these were the genes that they described were possible to have the trivial trauma triggered effects. So in one of those, there's CAPNA1 mutations, that is 1I and 1C can be seen. So yeah, with that, I'll open the case if anyone has similar experiences and if you think that the gene is positive or not, or any alternative possibilities.
I think this is all very well explained. I just want to make a small addition from a clinical perspective. Before looking at images, if you have an infant or a child who has a neurological deterioration following a trivial trauma, think of vanishing white matter disease. This has been repeatedly seen and documented. But the imaging, of course, is very different.
Got it.
Yeah, just one small submission. Are parotid cysts known with this syndrome? I'm not aware. Or is that just an
No, I think that's incidental finding.
Yeah. So I was looking at the parotid cysts, and just the thing that comes to my mind offhand is Sjogren's syndrome. Of course, this age is not typical, neither is, So.
Thanks, Anish. So yeah, I think so. The point here is if there's recurrent trauma or recurrent stroke-like episodes with these changes, think of genetic abnormalities, and one of them are the channelopathy spectrum. So CAPNA1 mutation in this case, and other channelopathies as demonstrated in literature should be evaluated. Okay, if there are no further comments, we just wanted to highlight that case, and we'll move on to our next case. This is from Anish. Anish, is Dr. Vijay joined us? Any idea?
Yeah, he's joined us. Can you promote
is it
him
Dr.
to
Vijay
a
Ganesh?
panelist?
Is that Dr. Vijay Ganesh by any chance?
Okay,
can you just raise his hand? I can see one Vijay. Oh yeah.
Yeah, done.
1 minute. I've done it. Just Dr. Vijay, if you can just check if I've got an invite. Yeah, I think I can see you on the panelist list. Dr. Vijay, if you're there, you can go ahead.
Morning, sir.
Morning. Sorry, evening.
Sir. So this is a case of 3 year, 7-month-old female child presented to us with a complaint of fever and abdominal pain for past 1 month. Sir. The similar complaints was also present in 2023. But other than that, there is no other significant history in the family, sir, or any antenatal, perinatal, or postnatal history. Developmental wise, also the developmental normal child, sir.
Okay.
So in 2023, during the month of May, the child had fever and abdominal pain for 1 month, for which repeated OPD visits was done and oral antibiotics were started. Despite which the baby was not symptomatically better, sir. So the baby was shifted to a tertiary care hospital where the child was admitted as a case of PO and was evaluated further, managed with IV antibiotics. So the initial investigation showed an anemia, and various other workup for infectious panel was found to be normal. TB workup was also done, which was found to be normal, sir. But CECT abdomen showed mesenteric and retroperitoneal lymphadenopathy with moderate ascites and bilateral pleural effusion, sir. In view of this, and there was multiple splenic abscesses also. In view of this, a clinically suspected abdominal TB was suspected. So anti-tuberculotic treatment was started. This treatment was continued for 6 months. During the course of the treatment, the child was...
Okay, sorry. All right, yeah, go ahead, sorry.
During the course of the treatment, sir, the child was symptomatically better. And this intermittent period from December to the month of March, the child didn't have any complaints at all. Following which, during the year of 2024, so next slide.
So I put the images first. Maybe we'll just see the images first and go ahead. Is that
Right.
okay? Yeah. All right. Anish, if you want to record.
Nihaal, could we have the clinical presentation because there was a little more before we did the neuroimaging.
Okay. All right.
Yeah.
So in the year of 2024, the child was asymptomatic during the month till February till April, sir. And in the month of May, the child repeatedly again had fever and abdominal pain for 1 month. And there was 2 episodes of seizure for 1 day. The child presented to the same hospital for which PUO and antibiotics were started again. Workup was done. In this time, the workup was extensive. Bone marrow was also done, which was found to be normal. All infective etiology was found to be normal again. The only interesting factor was the ESR was persistently higher on both the sides, and CRP and PCT was higher. And there was a fall in hemoglobin. CCT showed the similar image, same as the last time. So they thought of an abdominal TB relapse and started on ATT again. CSF was found to be non-meningitic. MRI suspected of viral meningoencephalitis due to the seizure or leukodystrophy was given.
Okay, so now we'll go on to the MR. Yeah, sorry.
Yeah, so the child had 2 MRIs. One was done not in our center. It was done initially when the child developed seizures, and subsequently, once the child was brought to our hospital, we did the repeat MRI. Findings are essentially the same with some subtle changes. So we can see the flare axial images showing confluent supra as well as supratentorial as well as cerebellar white matter, predominantly white matter involvement. There is dentate hyperintensity. Subcortical U fibers are spared. Deep gray structures, gangliocapsular regions are spared. And there are some small cysts which are appreciated in the cerebellum. If we see in the next slide, please, the T2 weighted images. Yeah, if you see in the cerebellum, there are some small cysts which are appreciated, and brainstem is spared. And again, on the T2, the findings essentially mirror the findings of flare with sparing of the U fibers. There is no obvious deep gray changes. We have the next slide, please. So no diffusion restriction on the current scan, no areas of any microhemorrhages or obvious bleed that are seen. Next slide, please. In the post-contrast, there were subtle areas of nodular enhancement, mostly within the cerebellum, which I've marked out, as Nihaal is pointing, small areas of nodular enhancement. And supratentorial white matter, nodal enhancement. Unfortunately, we don't have the non-contrast even weighted images, but there was a slight hypodensity, less than that of the normally myelinated white matter that we saw. So yeah, I think somebody's already answered in the chat.
Okay.
So could we?
So yeah.
Following which they suspected a relapse of abdominal TB for which ATT was started again. The child developed a DILI and the ATT was stopped and the baby was shifted to AHRR. At our setup,
sorry.
At our sorry, next slide.
Yeah, go ahead.
At our setup, on initial, the vitals were found to be normal. The child had hepatosplenomegaly and no other markers. And initial investigations found to have same anemia with raised ESR and CRP. And all other investigations of infections was found to be normal, sir. USG abdomen was found to have hepatomegaly with splenomegaly. And PET CT showed reactive lymphadenitis, bilateral cervical, bilateral axillary, and bilateral mesenteric lymph nodes were found, sir.
Okay. All right. So I think someone already has put it up on the chat. The imaging findings, Anish, you want me to summarize?
Yeah, please go ahead. So I'll add a twist to the tail at the end of it. Yeah.
Got it. So differentials for the second scan, at least based on the neuroimaging, we thought was the HLH as the primary possibility, given that the supra and infratentorial involvement and the nodular type enhancement, which is commonly seen in HLH variants. The other differentials to be kept in mind were other inflammatory disorders, some neoplastic abnormalities, but the primary consideration was HLH, lymphoma, sarcoids for the other differentials, which can have somewhat similar changes, but some, again, differentiating features such as the pituitary involvement in sarcoids is common, cranial nerve involvement is common. And demyelination, not that a classic example, but yeah, just to be kept in mind as a less likely differential. And other histiocytic spectrum of disorders, as you can see, the posterior fossa findings can be similar to what we have seen in our case. So these are the imaging differentials for the second scan, and HLH was the primary consideration.
So the initial investigations as mentioned here, sir, all findings were found to be normal. and following which the child was empirically started on antibiotics, but the child did not respond. There was another spikes of fever persistently going on. And the incidental finding of massive splenomegaly was found. So the initial spleen was found to be normal in size, but it gradually increased in size. It went to Hackett stage 4. And following which a whole exome sequencing was also sent, sir. The initial investigations was, so the initial differentials were kept in mind of primary immunodeficiencies, autoinflammatory syndromes, and storage disorders.
So this is before the MRI or after the MRI?
So the MRI,
the second MRI.
So if I'll just pitch in there. These were all sent after the second MRI. On the second MRI, we raised the possibility of a primary familial HLH.
Okay, got it.
So yeah, based on that, we sent the whole exome sequencing.
So based on this, various opinions were taken, sir. Optal review was found to have bilateral grade 3 papilloedema, sir. It was not even resolved. Since past 1 month, it was persistently present. Rheumatological workup was also done, which was found to be normal. PID workup was found to have minor elevation of IgM, sir. And pediatric neurology consultation was done in order to look for any autoinflammatory disorders, autoimmune disorders. Autoimmune panel of CSF was found to be normal.
So finally, the radiologist helped out.
Yes.
All right.
So the whole exome sequence was photodiagnosed to have congenital HLH. The mutation was PRF4.
So PRF4 or PRF1? Sorry. Oops. All right. Okay, so we have a whole exome pathogenic variant of an HLH, I mean, primary HLH. So, okay. Yeah, any comments from the panelists or the audience regarding the case? I think there are comments. There's the question of the bone marrow analysis from Dr. Riaz.
Yeah, so the bone marrow was done. It did not show any hemophagocytosis. So, but then it may not be seen if you go by the HLH diagnostic criteria. Yeah. So I think that was the question.
Yeah.
So the if I may just add to it, Nihaal, can I please share my screen? Yeah.
Yeah. Sure.
Yeah. Yeah. Is it seen? No. Yeah. Just a bit. Yeah. Yeah. Should be seen now. Is it seen?
Not yet.
No. Not yet. Just a minute.
Abhishek, do we have to change any settings for him to, for Dr. Anish to be allowed to share the screen?
Trying to share my screen, but. Unfortunately, so the child has been, I'll just go ahead with the presentation, not able to share my screen. So the child has been started on therapy, steroids and intrathecal methotrexate with a plan for workup for a bone marrow transplant. But a couple of days back, the child developed bilateral blindness. So we did a repeat MRI today and we found features of florid press. So which is a known feature. HLH on treatment is highly prone to develop press. We found posterior occipital, cortical diffusion restriction, and flare hyperintensity, which is a known complications. Almost 70 to 80% patients may have press once you start on steroids and intrathecal methotrexate. So that was just the addition that we had. That's the latest, and we just finished the imaging this afternoon.
Right. Yeah, thanks, Anish. Yeah, if anyone has any similar experiences, complications of HLH, steroid treatments, press, ocular abnormalities, more than welcome. Okay, I don't think we have any additional comments, but I think imaging-wise was fitting for HLH, so that was at least helpful.
Yeah.
And just a question to Dr. Vijay: the MLD was that a neurological diagnosis or radiological diagnosis? Because it didn't look like an MLD.
So actually,
Yeah.
Yes.
I'll just,
Sorry,
the MLD was largely, I think, initially reported, a lot of clinical features were not available, and
Okay.
only
Got it.
a section of flare images without contrast was available. So I think
Got it.
white matter
Okay.
involvement with sparing of the U fibers, that is why the
Got
MLD was raised, the possibility,
Okay.
yeah. But
Okay.
we had a lot of information was missing.
Okay. Got it. All right. Thank you. I don't think there are any further comments. Hopefully, you can send me the follow-up scan. I can put it up on the next meeting. Okay. Thanks. Thanks, Anish, and thanks, Dr. Day.
Thanks.
Apurva, over to you. Next case. This child, currently 18-month-old female child, this child presented to us at 6 months of age. So 10 days back, around 6 months of age, the child had 2 episodes of abnormal paroxysmal events, sudden onset uprolling of eyeball with generalized tonic posturing of the limbs with drooling of saliva, lasted for 2 to 3 minutes, couple of episodes in a day, associated with post-ictal drowsiness. Apart from that, the child had global developmental delay. At 6 months, the child had just attained partial neck holding and partial rollover. The child was not reaching for objects. Eye contact was present. Smiling was present. Cognition was better than the motor development. There was some tracking of objects. Loud sound-induced startles were there, and the child had microcephaly. That time, scanning was done for this child, MRI brain scan, which showed.
Yeah. Apu, were the seizures controlled or was it refractory? Sorry.
It is refractory, so even now the child is on drug refractory.
Okay. All right. So this was a scan done in October 2023, if I'm not mistaken, at that point of time. Diffusion and the ADC sequences, we have almost symmetrical abnormalities involving the pyramidal tracts, the cortical spinal tracts, the globus pallidi on both sides, also involving the chiasm and possibly the mammary bodies out there. The brainstem also demonstrates some degree of diffusion abnormalities, the decussation fibers, the central tegmental tracts. So predominantly central abnormalities of restricted diffusion on both sides. Corresponding T2s again demonstrate the changes which we have seen on the diffusion sequences. You can see more clearly the involvement of the plics, the pons out there, and also some areas of the middle cerebral peduncles. This was a child at around 6 months, if I'm not mistaken. The corpus callosum is also slightly thin. There is some degree of brainstem hyperplasia. So these are the initial changes on the first scan. And at that point, we raised the possibility of these disorders. Spectroscopy wasn't done, but this was a differential which we had given NKH, ITP, encephalopathy, bigopathies, tRNA disorders, and less likely possibility of a neonatal hypernatremia. Anything in between? I think there's a follow-up done 6 months later.
Yeah, currently the child developmentally, the child is completely delayed, not attained new milestones, having drug refractory epilepsy, and it's a consanguineous marriage, and also there is a history of the early sibling death. The elder child, that child also had developmental delay with refractory seizures, and for that child they had done urine GCMS. The report was not there, but they had written NKH as a possibility. So because of previous sibling and this sibling, then we went ahead with whole exome sequencing.
Okay. So the follow-up scan, I'm not sure at what if there was child was currently seizing or not. But yeah, if you see the follow-up scan, there is some degree of volume loss, but there is more extensive abnormalities in terms of diffusion changes, predominantly involving the white matter structures, also the globus pallidi out there, the brainstem structures, and now also progressing in the posterior fossa involving the dentate nuclei. T2 sequences, again, you can appreciate the progression in terms of the predominantly white and also some degree of gray matter abnormalities. Brainstem is been showing progression, cerebellum in terms of the dentate nuclei involvement showing progression, and there is overall generalized volume loss in the supratentorial brain and also in the brainstem. Keeping the initial differentials as possibilities, some additional considerations, especially given the diffusion abnormalities and progression. So it does not fit vanishing white matter because it doesn't reverse on the flare on T1 sequences. Some possibilities for homocystinuria, as you can see, have similar diffusion pattern and extensive white and gray matter abnormalities. Canavan species, again, we did not do a spectroscopy. Can also have some degree of extensive involvement, predominantly white matter, but globus pallidi involvement also can be seen. So we were going with the initial differentials of the ITP NKH mitochondrial disorders, and these are additional abnormalities based on the second scan. The child underwent an whole exome sequencing.
It came out to be ITPA-related encephalopathy. And one additional odd finding was that this child, those initial episodes of uprolling with tonic posture, when EEG correlate was done, that time there was no ictal correlate. So they were oculogyric crisis, which has been only reported in just one case report from Ludhiana. So that is one additional finding in this variant.
Okay, so I think Romit has asked for EEG. I think you've answered that. Dr. Shiji has asked for glycine levels. So that is it. Dr. Siddharth is asking for red nuclear involvement. Let me check. Yeah. So entire midbrain is involved. So the question was for refractory epilepsy and microcephaly. The main question was given that the central involvement of the ITP encephalopathy, the clinical phenotype at least has commonly presents with progressive microcephaly, refractory epilepsy. So the main teaching tip we wanted to share was if you see diffusion changes, especially in the central regions of the brain, and the child has microcephaly, refractory epilepsy with possibly additional cardiac and ocular abnormalities, to think of ITP encephalopathy other than the other differentials such as NKH, tRNA disorders. Yeah, I'll open the case if anyone has further comments. I personally haven't seen this extensive involvement on the follow-up scan. The typical ITP as seen over here look more like the initial scan. So if anyone has a fully blown out ITP encephalopathy, or is it secondary to a seizing either or excitotoxic brain injury, that would be it.
Was there any cardiac involvement?
No.
Dr. Romit says Dr. Vivek has shown glycine elevation, so elder sibling report of raised glycine might not be entirely wrong. Yeah, Romit, I think I remember this. I think the child had myoclonic epilepsy, if I'm not mistaken. Spectroscopy wasn't done, Dr. Vijay, for both the scans. Any cataract?
No cataracts.
Yeah. Okay. So yeah, I don't think we have any further comments or suggestions. So that was the case of ITP encephalopathy, mimicker of NKH. Spectroscopy is helpful, as Dr. Vijay has pointed out. Look for the glycine peak if you have similar imaging findings. If negative, then think of ITP, especially in a child with refractory epilepsy, microcephaly, and other systemic findings. All right, from Hyderabad to Pune, Krishna Priya, over to you.
Thank you, sir. This is a 1 year, 2-month-old male child, second born to non-consanguineous marriage. There is no relevant family history. Child had a normal birth transition. Child was AGA, had a normal development till 11 months of age, and then had a non-specific fever, following which the child lost all the achieved milestones and developed extensive spasms in clusters. And these spasms had partial response to ACTH. Child was on valproate and vigabatrin as well. And the child also had abnormal LFTs. For this child's one MRI was done outside before coming to us. And as a part of West syndrome workup, since we were suspecting genetic cause for the West syndrome, we sent the clinical exome. And
Okay.
the result.
Let me show the image.
Yeah. Yes, sir.
So at 1 year, 2 months, we have scans. On top is a diffusion. I could not appreciate any areas of restricted diffusion, no focal or extensive abnormalities. On the T2s, you can appreciate there is a volume loss in the supratentorial brain, predominantly cortical volume loss. The DPD nuclei are relatively spared in terms of volume and signal abnormalities. The brain stem, at least for a 14-month-old child, was slightly abnormal You can see that there is hyperintensities along the periaqueductal regions, the cerebral peduncles out there, the pons, and also the dentate nuclei demonstrated these T2 hyperintensities extending up to the middle cerebral peduncle. Also, the medulla you can see is demonstrating T2 hyperintensities, which we thought was abnormal for a 14-month-old child. And no structural abnormalities, at least on these images. But yeah, overall volume loss with brainstem and post-cerebellar T2 hyperintense changes, possibly some areas of delayed myelination out there, or some signal abnormalities. In terms of T1 various sequences, again, could not appreciate any focal abnormalities on the T1s. And the SAT sequence, we can appreciate, again, there's volume loss of the brainstem structures, the corpus callosum for a 14-month-old child. The coronal sequences, again, you can appreciate the midbrain structures, the substantia nigra, the cerebral peduncles, and the dentate nuclei, slightly hyperintense even for a 14-month-old. The SW sequences, I could possibly appreciate some degree of mineralization or blooming in the inferior globus pallidi and also in the ventral brainstem out there. These two areas, so we thought were slightly abnormal for the age. And just to put out a comparison for the posterior fossa signal changes, this is just a comparative control. As you can see, our child had slightly hyperintense cerebellar white matter structures and the dentate nuclei and cerebellum. If you see, if it corresponds to almost a 13-month-old, the dentate nuclei signal changes should appear like this, but our child has slightly more hyperintense changes. So, I mean, at least imaging-wise, some degree of neurodegeneration with the posterior fossa signal abnormalities is what we can comment upon at this stage. So, Krishnapriya, if you have the, I think with this imaging findings and the clinical suspicion of West syndrome, clinical exome sequence was sent.
Yes, sir. With this, the clinical exome was sent and the report came as WDR45 loss of function mutation, which was hemizygous, and it was corresponding to brain iron accumulation, which is BPAN, and it was X-linked dominant hemizygous pathogenic variant. So it was a BPAN mutation. The child did not have any dystonia or any movement disorder at present.
Is it too early to get that at this stage, or does it develop later on? The dystonia.
Pardon, sir?
The dystonia, does it present now, or can it present later on?
When going through the clinical impression, it is mentioned that it can develop later on.
Okay, with Parkinsonian features, if I'm not mistaken, later in order.
Yes, later on it might develop.
Yeah. Okay. So yeah, Jay and Krishna SW images, I've shown them to you. Let me see. These two are the SW sequences or the GRE sequences. So some linear areas out there in the globus pallidus and over here on the ventral brainstem. And BPAN clinically, I think the WDR45 mutation can have these clinical phenotypes. The most common is the BPAN. Can also have a Rett-like syndrome or West syndrome as seen in our case. And this is the function of the gene mutation. It impairs the autophagal mechanisms, can also affect the mitochondria and iron homeostasis. This is a good flowchart for the approach of NBIAs. This is from Dr. Lazaro, from one of his lectures. As you can see, the WDR45 mutations, that is the BPAN, in the early presentation, it can have predominant involvement of the substantia nigra and dentate nucleus, and later on there is the sign known as double hamburger sign or the halo sign, which I will demonstrate on the following slide. So this is usually present later on in life at around close to 10 years or close to puberty. As you can see, there is a T1 hyperintensity with a T1 hypointensity, and again there's an internal T1 hyperintensity is described as the halo sign or the hamburger sign, which is known to be commonly seen in the BPAN mutations. But the most earlier findings for the BPANs described in this review were the T2 hyperintensities involving the dentate nucleus and the cerebral peduncles or the substantia nigra. So look at these findings in case of a child with neurodegeneration and additional findings. The SW signal changes commonly are seen in children from 2 to 7 years of age. Again, T2 hypointensities can also be seen later on. This child is only 14 months old, so maybe it might present later on as the child progresses. Yeah, so that is the case, and I'll open the case for any further discussions, comments, similar experiences.
Am I understanding you correctly, Nihaal, that the image in this child is not really characteristic for BPAN? I mean, you know the diagnosis by the genetic testing.
Yes.
But
I mean, Yeah.
And also, I think my experience is close to zero. I've seen one patient, and it is said that the BPAN is static in early childhood, but only later leads to deterioration. So this is also a rather dramatic clinical presentation, isn't it?
Yes. Does it present more in the West syndrome phenotypes? I'm not sure. Dr. CG mentions that the same mutations can cause spasms and epileptic encephalopathies with which might develop dystonia later on. Yeah.
This is Dr. Prerna. Could it be like a spectrum of radiological findings that we see with this mutation? Like we could see this thing early on and then sort of getting the more BPAN type picture later on as the child progresses.
The atrophy, yes, but I mean, I would be very impressed if someone called it as BPAN on this image alone.
Not BPAN, this
sorry.
WD-DR45 sort of spectrum of radiological findings, maybe. I don't know. Like if we have a lot of cases, I mean, if we have a few, we could club and see whether they have these changes initially and then develop.
I think you're right. Expanding spectrums are very common. But if in general, this is not relating to this child, if the case falls out of the usual spectrum, you should think of whether the diagnosis is appropriate or whether you deal with the dual diagnosis. This is not uncommon. So atypical cases are often dual diagnosis.
Yeah, totally agree. Just one question I had, whether the BPAN can have such acute decompensation during a febrile illness, because usually it's understood to be a slowly progressive disorder. And of course, the radiological changes sometimes may come later, the clinical phenotype may come later. But such an acute deterioration with a febrile illness, like, is it, we didn't find much references for that. Has anybody amongst the participants seen such a presentation? Because then I think, as Eugen sir pointed out, we should think of some other either associated dual pathology or maybe a completely different disorder maybe there. To answer Jane's question, yes, microgenome was done, and that was no.
I don't think anyone.
Dr. Shiji, so we had seen a same mutation who presented with epileptic encephalopathy, presented to us later, but initial presentation was spasms, but no acute encephalopathy or decompensation like picture in that child. Not seen, ma'am. But the MRI done at 3 years of age definitely showed the blooming. The iron deposition was more. And she developed movement disorder as well by that time.
Yeah, okay, thanks, Shiji.
Dr. Prerna's comments, yeah, probably part of the spectrum is spasm and BPAN, like channelopathies. Okay, yeah, so clinically slightly atypical, as Dr. Kavita and Krishnapriya mentioned. Imaging wise, not very specific at this stage. Maybe later on we might have some additional findings which are more specific for the disorder. So, are you planning to follow up, Dr. Kavita or Krishnapriya, or what is the next? How do
Yeah, I mean, we are
treated?
just managing like a usual West syndrome, symptomatic West syndrome, and continued the steroids as of now. And we'll see. We are planning to do the parental studies as well.
And vigabatrin is there for how? What is the duration?
I think it's just 6 weeks.
Okay.
So we've just finished the ACT at 6 weeks. Yeah.
At least there are no vigabatrin changes on the MRI. Okay. Jayant comments anecdotal evidence of iron chelation in ongoing trials in NBIM. Jayant, if you have the reference, you can just post it. Otherwise, we'll check it on. Thanks.
See that we have tried as well the iron chelation. They don't work actually. For the pecans we have tried, they don't work.
At this point, I would clearly refrain from, because I don't think anything is matching with the BPAN except the genetic finding that we've got. So at this point, I'll just wait and watch and see, treat him like a usual Best syndrome and see how it develops. Yeah. Thank you.
Right. Thank you. All right, Anas, what are you?
Yes, good evening. So this is about a 5 or 10 months old boy. He was developing normal, asymptomatic till April 2024. He had fever and parotid swelling for 2 weeks. He was diagnosed clinically as mumps and treated accordingly, conservatively. The fever and swelling subsided gradually. During the afebrile period, on April 11th, he had inability to pass urine and stool, acute onset, and also lack of sensation below the neck, pain, touch, temperature, all were lost. And there was acute onset lower limb weakness. He was admitted the same day, and next day developed encephalopathy and weakness of upper limb and truncal weakness. He was admitted to the hospital for 20 days total. With IV agent steroids, there was improvement in sensorium gradually within 1 week, and upper limb movements increased over 2 weeks. Bladder required intermittent catheterization, and as of now, still requires catheterization. There was, despite upper limb movement improvement, there's still lower limb weakness persistent, static as of now. As of now, July,
Anas, well, hold on, I'll just show the images. So after the presentation in April, the child underwent an MRI, brain and spine. So in the scan in April 2024, you can appreciate multifocal abnormalities, predominantly involving the peripheral regions of the brain, that is subcortical, cortical regions, both the hemispheres, more on the right side, as you can see out here. Also, the deep brain nuclei involvement is present, the basal ganglia on both sides, along the anterior commissure out there, and also some areas in the temporal lobes on both sides. The brainstem also demonstrates some areas of focal abnormalities, particularly in the pons and cerebellum. If you look at the inferior cerebral hemisphere on the left side, there are some abnormalities around the periphery. So multifocal abnormalities involving the gray and white matter structures, predominantly gray matter structures. And that's the spinal cord T2 non-contrast SAS sequences. You can appreciate long, extensive myelopathy. And on the cross-sectional images, it is involving almost the entire, more than 2/3 of the cross-section of the spinal cord, some selective involvement of the central gray matter, lower down in the thoracic region. Predominantly involving the central regions, the gray matter structures, and extensive myelopathy. Post-contrast was done, and there was some degree of enhancement, not severe, but mild enhancement of the quad-equine nerve roots, as you can see on the SAS sequence on the second panel. And also the axial sequences, you have some areas of involvement of the quad-equine nerve roots. The parotid glands, given that the clinical suspicion of mumps, as you can see, this is the diffusion sequences. There is some area of restricted diffusion in the bilateral parotid glands, which is slightly swollen. So possibility of acute parotiditis was considered. And the differentials at that point, given that the child had mumps, so you have these differentials for parotiditis, and the primary suspicion is mumps, and other differentials are the other viral organisms which can also present with parotid gland inflammation. The intracranial findings, again, mumps can present with multifocal abnormalities, more diffusion-related changes which are not present in our scan. MOG antibodies for the para-infectious demyelination was another consideration, given that the multifocal appearance, long segment myelopathy, predominant involving the central cord, was another differential kept based on imaging. And this is a good poster, I think, presented in the SPINAR 2022 by Julia Pavane and Manchester group. And if you see the approach to the spinal cord involvement, you concentrate on the blue and the red pattern. That is, the blue pattern has predominant central gray matter involvement that is commonly seen in demyelinating disorders such as MOG and ADEM. And the holocord involvement, again, commonly seen in demyelinations such as NMO, but more commonly in the acute transverse myelitis spectrum of disorders. The spinal nerve root enhancement, again, these are various differentials. DBS, I don't think has the additional parenchymal abnormalities, spinal cord abnormalities, but yeah, just to be kept in mind. Following that, I think the child was investigated and also to.
So, during that time, the clinical suspicion of based on the clinical radiological spectrum, MOGAD was suspected. Child received IVIG, IVMP, and then on OP basis, child was followed on OP basis. He had received 2 doses of rituximab in view of suboptimal improvement in lower limb weakness, and started on mycophenolate mofetil with steroid taper. So as of now, they've come here for a second opinion. So on examination.
Okay, understood. I think I have one more scan.
Yeah, this
before the
interval
child. Yeah. So the another scan done, I think, at the primary center in Vijayawada, you can appreciate that the multifocal abnormalities has demonstrated interval reduction in terms of the focal abnormalities, some residual changes in the deep brain nuclear structures, also in the brainstem. But at least the multifocal abnormalities are slightly reduced. You see the diffusion change on the parotid gland, the swelling has come down. This was the spinal cord sequences. There is again some residual abnormalities, but if you observe from the first scan, there is some degree of volume loss, especially in the thoracic cord and the lumbar cord. Again, persisting abnormalities involving almost the entire cross-sectional area of the cervical and lower upper thoracic cord, possibly a cystic structure out there in the mid-thoracic region, which corresponds to this level out here. So yeah, these are the interval changes. The brain does slightly reduce in the spine also, but there is also some interval degree of volume loss in the spinal cord, especially. Yeah, then we have another follow-up scan done recently, but before that, the clinical presentation of the child. Yeah, Anas, over to you. Anything now recent?
So we have examined the child that there's absolutely no power in the lower limb, and so shoulder there's 3- power, partial movements against gravity, elbow and wrist 4/5, good movements. Lower limb 0, no power at all. There's absent cremasteric reflexes, abdominal reflexes, and brisk upper limb reflexes, lower limb areflexia. There's a clear sensory level at T5, and he had no sensation, pain, touch, temperature below T5. No autonomic dysfunction either. So we are wondering if this could it be just a sequelae? I mean, just not just MOG alone, but mumps any anti-root involvement as well or not. That was the suspicion. So we had repeated MRI spine.
All right, repeated MRI spine demonstrates again only spine was done. So again, residual changes in the cord, predominantly in central regions, but again there is further interval progression in terms of the volume loss. Again, more in the thoracic and the lumbar spine. On post contrast, only the LS spine contrast was done. You can appreciate some degree of enhancement in the cortical nerve roots, which corresponds with this level out here on the STAT sequences. So yeah, some mild enhancement was there, but again there is if you compare with the first scan, there is significant interval volume loss, possibly related to some variant degeneration out there of the spinal cord. The main question here is, as Anas has pointed out. Sorry, go ahead. Yeah.
It's a previous slide. So initially the child was tested for, in the initial admission, lumbar puncture was done, which showed CSF cellularity of 150 cells, 60% neutrophils and 40% lymphocyte. The culture was negative. I think based on the initial radiology, Lyme serology was sent as well. It was negative. MOG, which was sent at Amrita, was strongly positive fixed cell-based assay. Now currently this admission we have done nerve conduction study, which shows absent CMAPs in both perennial and tibial nerves.
Can I jump in? What do you mean by no autonomic dysfunction? Do you refer to bladder and bowel and to splitting, or
no, blood pressure, or
I mean, in this situation, from the descriptive term, you have a extensive myelomalacia involving the conus, and you would definitely expect a neurogenic bladder.
Yeah, he still requires intermittent catheterization and requires laxative to pass stools. So those kind of, I meant no local autonomic dysfunction. But yeah, he does have significant autonomic dysfunction in terms of bowel bladder.
Thank you.
So the main question here is we're asking is anyone has experience, if we are suspecting based on the lab report of MOG, has anyone seen progressive spinal cord atrophy in children with MOG, or is it a primary viral related abnormality with a parainfectious lab finding? The second question is, I think treatment wise, Anas, correct me if I'm wrong, you want to start flex or trying to start flex?
Would there be any role in doing flex so late into this thing, considering there's chronic change in the spinal cord?
Yeah.
MOG antibodies can be measured for 10 years or less. So as a dinosaurier clinician, I have experienced post-myelitis extensive myelomastia at the time when MOG antibodies were not yet able to be measured. So this is unfortunately not uncommon following myelitis. It's either an inflammatory plus a vascular component. And then if you have a longitudinal malacia, you expect neurogenic bladder. You cannot measure nerve conduction velocity because of Wallerian degeneration. You have areflexia, and you have no power, and you will not develop spasticity. In contrast, if you have an intact lower spinal cord, say following a high traumatic tetraplegia, where you develop spasticity, this patient will never develop spasticity. Was that confusing enough?
No, that was clear. Yeah, no, that was clear. Main question here is the immunomodulation is already been extensively immunomodulated, and with the already atrophic lesions in the spinal cord, we probably think he may not benefit much from further immunomodulation. So if everybody agrees, we would also want to stop the further immunomodulation aggressively.
Hi, this is Namrata Shah. Sorry, I'm driving, so I couldn't join earlier. But I think if you look at MOG literature and all the different phenotypes it presents with, myelitis is one of the worst, especially when they have an LETM presentation. Even if you've done everything initially, did this child get plex? Sorry, I missed that point. Did she get a plasma exchange?
No, that was the. Sorry, go ahead.
No. Yeah, so plex would have been a good thing to do on this child. So I think combining steroids and plex in the acute phase when they present initially, and then you can do IVIG, rituximab, and continue. But I agree that, myelitis has the worst outcome, especially when there is conus medullaris involvement in MOG. Then the bladder bowel function may not return back completely, and they can be left with significant neurological deficit. We have currently a patient who had a high cervicothoracic lesion with MOG or LETM extending more than 6 or 7 segments, and she is still quadriplegic. Luckily, her breathing is not affected, so she doesn't need a trach or a ventilator. But in spite of all the treatments that you all have done, but she did even get plex in the first week of presentation. So initially she got steroids, then I think IVIG, and then when she wasn't getting better, the team gave her plex, and she received rituximab. But I don't think, especially now, if the MOG antibody was strongly positive, have you all repeated a MOG antibody recently?
Not yet, but we intend to do one if it would add to the diagnosis or treatment management.
Because if the MOG antibody is coming down, like our patient is now negative, her titer was 1 in 100. We send ours to Mayo Clinic, and when she came in, she was 1 in 100, but now she is negative. So my colleague who's managing her, I don't think further immunosuppression is going to be of much utility, because if she did have the H sign, I'm sorry, I couldn't see her imaging well, but if she had involvement of the gray matter and conus medullaris, the likelihood that she'll improve more with more immunotherapy is low. Definitely, the regular therapy, OT, PT, bladder training, all that is important, the rehab. But I don't know if you've given her adequate doses of rituximab, she got adequate steroids with a slow wean. I don't know if additional immunotherapy will make a big difference to her outcome.
Thank you.
Thanks.
Thank you, Dr.
Thank you.
Dr. Riaz raised a question. Sorry, go ahead.
Sometimes the nerve root enhancement that we see along with MOG, is it just associated or just
yeah, it is. It is one of the.
Okay,
In
okay.
terms
It
of all the
does.
demyelination, the most common one is MOG. I mean
Okay.
that the MOG NMO and the MS MOG is can show coronary enhancement.
Thank you.
There is a very good article in JAMA Neurology from I think 2022 or 2023 by Dr. Flanagan. He's at the Mayo Clinic, and it talks about mainly MOG myelitis and outcome. And it tells that not everybody is going to recover. Like most of the MOG other patients, like ADEM, even optic neuritis, if they are treated appropriately, adequately, they do well. But myelitis is one of the condition like localizations which has a worst outcome. Especially there was, spinal cord and conus medullaris involvement. So they may be left with residual benefits. So I'll try to forward that article when I get to work to one of y'all, and then y'all can share with the rest of the group.
Thank you.
So thanks.
Okay, thank you.
There's a comment from Dr. Riaz. Look for fibs in EMG. Prognosis may not be good. I'm not sure what fibs stand for, but yeah.
The fact that you have no measurable nerve conduction velocity, areflexia, and no movements means you have extensive damage to the lower cord. Whether you use EMG or not, this has a very unlucky outcome.
All right. So I think the consensus is
Thank you. Yeah,
flex not
repeat
required
the
as of
MOG.
now. Repeat the MOG.
Yeah,
and
repeat
paste.
the MOG. Yeah, sure.
Yeah.
Thank you.
Okay.
Thank
Thanks.
you.
All right. Next case, Apurva.
So this child is a 2-year-old male child. Previously, the child was developmentally normal. The child came with complaints of history of weight loss from last 2 months. The child had lost 4 kgs. He was 14 kgs before, and now the child was 10 kgs. Presented with complaints of right side upper limb more than lower limb weakness that was noticed gradually past 7 days. The child, when we examined the child after 7 days, the child was conscious but irritable. There was no facial weakness, no pseudobulbar dysfunction. Right upper limb, lower limb, there was hypotonia with gastric nemes, spasticity, and brisk reflexes. Power in right upper limb, shoulder abduction was 3/5, elbow flexion 3/5, and wrist extension was 2/5. And hip flexion, anti-gravity movements were present. Knee flexion also anti-gravity movements were present. So upper limb was distal upper limb more than lower limb was affected. There is also history that the grandmother who's staying with the child has history of tuberculosis, open pulmonary tuberculosis, for which she is on anti-tubercular therapy last 6 months. And with this background, scan was done for this child.
Okay, just to point out, the family history was not provided at time of scan. Okay. All right. So we have the initial scan. I think only one scan. So on the diffusion, you can appreciate there are some lesions out here. They did not show reversal on the ADC sequences. So some bright lesions on the diffusion weighted panel, but it did not completely reverse on the ADC sequences. Possibly some T2 shine through out there. On the T2 weighted sequences, you can appreciate there are some alternating signal changes involving these lesions with significant perilesional edema. The right frontal lobe, the left temporal parietal region, the left the thalamus, the posterior limbical capsule, posterior putamen has the lesion out here, and also the subcortical cortical regions of the right the posterior temporal occipital lobe has another lesion. So total of approximately 4 lesions, significant perilesional edema. T1 non-contrast sequences, the central regions of the lesions are slightly hyperintense. The central aspect has hypointensity with another alternating band of slightly T1 hyperintensity. Again, another T1 hypointensity with perilesional edema. The SWA sequences, I could appreciate some punctate foci of blooming on the periphery of the lesion. Some possible foci in the inner band out there. Also in the occipital lesion out here, only the periphery has some punctate areas of blooming. Post contrast, there was no meningeal enhancement, but the lesions demonstrated this thick, slightly irregular enhancement, some internal projections out here going up in the lesions, especially in the left temporal parietal abnormality. Even the central abnormality has some thick irregular enhancement, especially on the inner aspect. Spectroscopy was done in the basic ganglion, the posterior limb capsule lesion, and you can appreciate a significantly elevated lipid peak out here, slightly elevated choline peak. Other than that, there was possibly some elevation of the cytosolic amino acids, but not very significant. At least that is what I inferred. But main findings I thought were the lipid peak out there, and also the slightly elevated choline peak. Yeah, other than that, I'm not sure if there are any significant peaks. I think we have Dr. Vijay if he wants to comment upon that. But additionally, the spinal cord demonstrated another lesion out here in the intermedullary portion of the lower cervical region. Centrally, slightly hypointense with peripherally hyperintense and a long segment myelopathy and possibly some perilesional edema, but again some myelopathy extending almost up to the upper lumbar spinal cord. Post contrast, there is almost diffuse enhancement of the lesion, no meningeal enhancement in the spinal cord. So single lesion in the spinal cord, 4 lesions in the brain. And the differentials primarily we thought of was tuberculosis, tuberculoma as one of the possibilities, which can also have a similar spectroscopy peak. I'm not sure of the other peaks out there in our scan, but the lipid peak is characteristic of tuberculosis as one of the possibilities. Fungal etiology, given that there were some areas of punctate blooming, some internal projections out there, was considered. The other possibility we thought of, again, spectroscopy can be similar, as you can see in this case out here, which has similar findings in our case. But I don't think there was any history of immunocompromised history. So again, similar lesions can be present with significant perilesional edema. The irregular enhancement pattern can be seen in the typical concentric eccentric ring pattern, as seen in this case over here, can be a possibility. So these 3 possibilities were raised. Sorry, Apurva, I think I missed out the follow-up. Maybe you can just.
Yeah, so sir, investigations that we had done, so CVP, CRP was normal, ESR was 22, MT, which was done when we read, it was strongly positive, it was 20 mm. Apart from that, from
MAN2 test,
MT
MT, many people.
MON2 test, which was done, which was strongly positive, it was 20 mm. Apart from that, we underwent with the biopsy of this left parietal region. In this biopsy material, there was a granulomatous tissue which was found, and the neurosurgeon felt that it was having a consistency like that of a tuberculoma. And the biopsy for that the biopsy sample, it was sent for culture, fungal staining, gram staining, Zn staining. The stains were all negative, but this biopsy tissue had low positivity for gene expert testing. Apart from that, the cultures we have sent for CSF cultures, and currently the child has been started on ATT.
Okay, so case is open. Any alternate possibilities for tuberculosis other than tuberculosis? There's question of immune status, from Dr.
Previously, no issue. No, the child was well thriving. 2 years old, he was almost 14 kgs. Never had any recurrent infections. BCG mark was present. There was no low TLC count suggestive of any, at least on the blood parameters. There's no such suggestion of immunodeficiency.
Chest abdomen screened, X-ray, ultrasound.
So chest X-ray is normal. Ultrasound abdomen is also normal. Thymus was also present. No absent thymic shadow.
I have a naive question, if you allow, from outside India. So you mentioned that the grandmother has tuberculosis. Am I correct?
Yes.
If you make the diagnosis of tuberculosis in an infant, are you screening the family? Are you looking for the source of infection? And how you do that? How systematically?
So for any child, whenever they present to us and it is a case of tuberculosis, the entire family is screened, at least chest X-rays, we ask them to get it done. And any possibility of finding of any abnormal lymph node or pulmonary infiltrates, then they are referred for tubercular clinic to adults.
Many thanks.
They all get the sputum examination as well, especially infant less than 1 year. If they have, so the sputum examination is also done for most of the family members. Only other dilemma I had in my own mind is whether we should have done the biopsy or we should have just started the ATT. we were, because it will be at least 1 to 2 years of treatment, these tuberculomas are slow to respond, and the spinal cord lesion is also there. So that's where the dilemma was there, because two positive evidence for us was the open case of tuberculosis and the MAN2, but we didn't have a microbiological. So we thought if we have some microbiological diagnosis, we can go on with the treatment more carefully. So that is the dilemma. If in a resource limited, or if the parents refuse the surgery, then whether we would have done just a ATT without surgery, biopsy. Other clinicians
traditionally, ATT is routine TRT practice, routine treatment practice to look for resolution. Okay. I think Dr. Riaz, the question was, would you have done, given directly ATT and not done a biopsy? Or I think that's the main question.
Because we couldn't do a lumbar puncture because of the spinal cord lesion, which was causing mass effect. So we thought it is at least some mass to reduce and then do this CSL.
Habib says CT chest contrast was worth doing for the source. Right. Dr. Shiji says usually start AKT without biopsy. Okay.
Thank you.
Okay. All right. So to our last case, Dr. Pena, over to you.
Yeah, so basically, I brought this child for discussion because we were not really coming to what was the cause of the initial presentation. This is a 6-month-old male child first born of non-consanguineous parents who presented with fever for a day, low-grade fever, and excessive crying, and on examination was found to have bulging anterior fontanel. There were no focal deficits. Reflexes were slightly brisk. But other than that, the child seemed quite happy post-feeding and after the initial 3% solution, anti-edema measures were given. So because of the child's age and the bulging AF, we initially, I think they had a CT scan done.
Yeah, I don't think I have the CT up. All right.
That was the first one. No?
No, that's the MR. So CT scan, I think I can just describe the findings. CT scan initially had bilateral subdural collections or hematomas on the left side. I think that was those are the findings, Dr. Rena.
Yeah, so I think basically in the left hemisphere, it was more dense. It appeared quite homogeneous as compared to the right side. The right side was slightly more CSF isointense. So the impression was given that there is a acute on chronic subdural hematoma on the left side, and subdural hygroma on the right side. So the first thought would be that this is a late onset HDN and coagulation profile, PIVCA2, all these things were done, which were all negative. The second thought came whether this was a battered baby or a shaken child syndrome. And so that was looked into as well. And the fundus examination was normal. Dr. Nihaal, did you have a chance to look at the CT to look for any signs?
Yeah, so I have 3 scans. I'll just quickly go through them. So after the first CT scan, this is the follow-up MRI scan, I think done 2 days later, if I'm not mistaken.
So the child, basically the first scan had shown midline shift to the right. So the neurosurgeon had tapped. And this was the scan following the first tap which was done. And the child showed some improvement following the first tap.
So the first MRI which we have here is bilateral subdural collections as previously demonstrated on the CT scan, but the left subdural collection has some degree of restricted diffusion. The membranes especially are demonstrating restricted diffusion. Some areas of linear areas of restricted diffusion out there. Some septations in the left subdural abnormality. As you can see, there is some mass effect, but not significant midline shift at this point. There is mild midline shift towards the right. In terms of the parenchyma, I cannot appreciate any abnormalities on the diffusion, possibly some cortical edematous changes in the left parietal region and maybe in the frontal regions out there. But yeah, in terms of the central structures, cannot appreciate any changes. This is the T1 non-contrast sequences. And on the T1 non-contrast sequences, there were some areas of focal T1 hyperintensities, possibly along the cortical veins out there, which are maybe have thrombosed, or which possibly we'll just have a look at on the SWS sequences. But the T1 again, you have the left collection is slightly more hyperintense in comparison to the right side, which is more similar to the CSF signal changes. And then coming down posterior in the posterior abdomen, you appreciate some subdural abnormality out there in the left retrocapsular region. And if you have a look at the T1 sequences in the bottom, the last two panels, there is some hyperintensity in the frontal sinus out there. We'll have a look at the SWS sequences if that corresponds with any hemorrhagic changes or not. T2 non-contrast and the flare non-contrast sequences, again, bilateral subdural collections, different signal intensities, some areas of focal hypointensities out here and the convexities. But yeah, so these are the changes on the flare sequences, again, going down and up to the occipital region, more on the left side. The SAD sequence again demonstrates the subdural collections, the separated subdural collections on the left side. The SWS sequence is demonstrates again the areas of blooming, linear areas of blooming, subdural collections, hemorrhage along the falx cerebri out there, possibly along the bridging veins in the convexity, some subdural hematomas along there, and some septations as demonstrated in the frontal areas on both sides. The frontal sinus, which we have seen in the T1 weighted sequences, demonstrates blooming, especially on the left frontal sinus. So possibly some hemorrhagic changes out here, or protein-rich changes. And on post-contrast sequences, you can appreciate diffuse pachymeningeal or dural enhancement on the left hemisphere, also along the falx cerebri, and also some cortical veins demonstrating some areas of peripheral enhancement out there. Leptomeningeal enhancement also demonstrated on the left side. And you can appreciate possibly some membranes out here, especially in the frontal lobe. The sinuses also demonstrate some peripheral enhancement. So I think the first, as Dr. Prerna summarized, the first MRI demonstrated the subdural hematomas, the CT scan was done, tapping was done. Oh,
So,
okay. So
actually, we had, so the CSF which was tapped from the left side was xanthochromic. And so it showed mild, of course, it was blood tinged. So there was mild elevation in the protein and glucose, but corrected counts were okay. The CSF culture and biofire panel were negative. Metabolic profile, including homocysteine, was negative, they were normal levels. Yeah.
Sorry, this is the first CT scan. So I just put up on the wrong slide, but yeah, this is how the first CT scan looked like.
I think about so 24 to 48 hours after the MRI, this child started showing a bit of irritability, and the parents felt that the sensorium was not, the child didn't look as bright. And the clinicians who were examining, they felt that there was some paresis of the right upper limb and possibly some ptosis. So over the course of time, the child started having fever spikes again and progressively deteriorated after the second tap. So the second tap was done because of altered sensorium. And then the child started showing all these focal deficits.
I think I have one more imaging. Okay, I think there's a follow-up MRI again.
Yeah.
Similar changes as what we have seen on the index, the first MRI, bilateral subdural collections, mixed signal intensity. Here you can see the diffusion changes are slightly progressed as compared to the first scan. There is some additional area of restricted diffusion, especially in the mid and posterior subdural space out there. The SWS sequences, again, some areas of blooming, especially in these convexity regions and the frontal lobes out there. Post contrast, again, similar enhancement pattern, predominant dural pachymeningeal enhancement on the left side, some leptomeningeal enhancement, some possible some membranous enhancement on the frontal lobes. And this is, I think, post tapping, we have another
so
CT.
This child was then referred to the government hospital because of financial constraints, and there they had put the drain.
Okay, so I don't have the bone window of the first scan, CT scan, but this is the second scan. And where was the tapping done, or was the craniotomy done by Prerna, or
No, I don't think
just
craniotomy was done.
okay, because the only thing was subnormal, at least I could find out, was along
Yeah,
here
so
in the
I don't
coronal
know the
sequences.
exact surgery that was done there.
Yeah, but you can see that there is some displacement
Yeah.
along these
Yeah.
sutures. If it was picked up on the first scan or not, since we don't have the bone window, I'm not able to tell that. But here you can see, at least in the parietal region and the going up to the occipital region, there is some abnormality, some sutural, means possibly some diastasis. We don't have a volume rendered sequence of this, but there is some abnormality, definitely abnormality, not commonly seen in infants. So this raises, initially we thought was possibility of a sequelae of an infection, but given all the findings, I think one must possibly consider abusive head injury or battered baby syndrome as a possibility. The collections are maybe on the left side are in the chronic stage because there is neomembranization formation, which also enhances, as you can see on the bottom panel out here. And the CT possibly indicates some degree of trauma to the brain in the posterior aspect. And there are also some areas of blooming on the convexity, which possibly relates to bridging vein thrombosis, as you can see out here. It's commonly seen in battered baby syndrome. So these are the differentials which we think of when we see this imaging findings. The infection was one of the differentials. I think the rest of the differentials do not fit into the child, especially on imaging. So I think we're going with the possibility of abusive head injury and possibly secondary infection as the primary two differentials.
Okay. So the cortical vein thrombosis that we were seeing in the initial one also, so that is secondary to the trauma, probably?
Yeah.
Okay.
So this is the first MRI. Let me see. So some areas of blooming out there, especially they are more linear, whereas over here you can see they are more extensive, but these areas. And then on post contrast, if you appreciate, there is only peripheral enhancement. The central areas are not enhancing. A thinner slice may have been more helpful, but the new membranization also is supportive of chronic subdurals. So I'm not sure if the 6-month presentation is the initial presentation. There might have been some trauma previously too.
So there's no history of any trauma as such, like the child had not fallen or anything like that. Not so sure about, the parents seemed very concerned and their body language didn't seem that they could be abusive, but we don't know.
No, I mean, trauma as in the non-accidental, I don't think will be reported openly, if I'm not mistaken.
Yeah, true.
Yeah.
But yeah.
So there's a question of can it be rapid cerebral atrophy, which is leading to subdural, but the cause of rapid cerebral atrophy needs to be attributed, right? So the rapid cerebral atrophy can be seen in some metabolic conditions such as Menkes, the mitochondrial disorders such as the RA-RS2 mutation, but this child doesn't have any additional imaging findings for the same. So I think the child has been glutaric aciduria, Sylvian Fishers.
No, TMS GCMS is negative.
Basal ganglia.
No, I think with calvarial fractures, there is only one differential diagnosis. There is no other possibility. Yeah.
So how come we are not seeing any anything on the? So we won't catch it on the MRI at all. Like it seems quite displaced in this one, in the CT. So I don't know whether this is like post iatrogenic.
No, I mean this is displaced. You can see over here. I think the holing is done in the frontal region. If I'm not, I mean the drainage tube is put in the frontal or the temporal region. But here you can see, especially in the post along the parietal region out there, and along the sutures, it is displaced.
Yeah, and it's communicated also.
So,
Yeah.
So I think we'll have to look back at the first CT, the bone window of the first CT, if there was any fracture at that point of time. I think these are 4 millimeter or 5 millimeter cut soft tissue windows. So if we can get a bone window for this at this point, the first scan, that would be helpful.
Sure, thank you.
You mentioned the fundoscopy was negative.
Yeah, no retinal hemorrhages.
Is it possible for the retinal hemorrhages in the chronic stage not to be picked up?
There should be some changes, I think, in the fundus.
Okay. But that doesn't rule out, I think, abusive head injury.
Yeah,
even though we
yeah,
don't
it's
have
not
that.
an exclusion criteria or anything.
Question for COL4A12 mutation related disorders from Aarti and Tamim. Call for at least imaging spectrum wise subdural. I'm not sure is a common finding. There are more porencephaly, hydroencephaly related abnormalities, parenchymal hemorrhagic changes. So this child doesn't have that. The atrophy also is not common. So yeah, I wouldn't put COL4 as high up on the list for imaging consideration. And I think Dr. Prerna has already mentioned skeletal survey is normal, but still the fractures around the posterior aspect and the other findings should point towards possibility of abusive head injury.
Yeah, and just a submission that it need not be the parents who are the perpetrators of the abuse. It could be, older sibling, peer, the child plays with, anybody can
Caretaker,
be.
it could be anyone.
Yeah, anybody.
Yeah. Thank you.
And this is a male child, right? Or female child? I don't know if there's still the distinction. Okay, all right. Yeah, so I think, Dr. Prerna, you probably have to raise. I think you mentioned that the child has left and gone to a different hospital, but still, I think someone has to be notified.
I think we'll flag the team there.
Yeah.
Thank you.
Okay. Thank you. And I think that's our. Yeah, these are a few references if you want to just look up non-accidental injuries and the differentials. So yeah, thank you. That's our last case. So thank you once again, everyone, for submitting your